joining us today as the National Board of Public Health Examiners presents the third in our series of 6 webinars geared to explaining the Certified in Public Health, CPH credential, and help you to prepare for the upcoming exam. You may register for the remaining 3 sessions on the MBPAG website. Today's session's feature is Health Policy and Management. The slides will be emailed to each participant after today's presentation, and we will also upload the presentation to the MBPAG website. We are pleased to have Joel Lee, Professor of Healthcare Administration and Director of the Doctor of Public Health degree program at the University of Georgia College of Public Health. Dr. Lee?
Yes, good day. Hi, this is Joel Lee at the University of Georgia. And before I begin, let me apologize. I'm on the tail end of a head cold, and hopefully I won't cough too much as we proceed. But I didn't want to reschedule, so hopefully we'll be able to make things work well today. As you've probably heard if you participated in any of the other sessions, I can't tell you what's on the exam because I don't know what will be on the exam. What I can do is seek to address the important topics that I would include in an MPH course in health policy and management, and I hope that will help you in preparing for the exam. I should mention, by the way, that I am one of the charter CPHs. I took the exam the first year it was offered, so I understand your interest in preparing to do well on the exam. So let's go on with the presentation. About halfway through my session, we'll take a little 10-minute break and then we'll resume. Okay, so in preparing my presentation today, I used 2 sources. I looked back to the master's degree core competencies that were developed by the then Association of Schools of Public Health, what's now the Association of Schools and Programs in Public Health. And I looked at the 10 competencies that were defined in health policy and management. And I won't take your time to read through those in detail. I suspect many of you, if not all of you, are familiar with them. They'll be part of the PowerPoint that you'll receive following the session. But I looked at that information. In addition, as part of that competency model, there are references to interdisciplinary and cross-cutting competencies. There's a separate session that's taking place on that topic. But several of those overlap with health policy and management. So I'll make reference to those as well, but I won't go into as much detail in those areas. The second area that
Hi, Joel.
Yes.
Hey, Joel. The sound's a little muffled. Do you think that we could start over and you could call in from the dial and information we're about to email you?
Okay, absolutely.
Okay, great.
Bear with me 1 second. I guess all of our testing, nothing is perfect. Okay, I'm about to dial in now.
Okay.
Should we restart the recording as I connect? I think I'm, can you hear me okay? I'm hearing an echo.
He has to hang up on this.
Okay, how does it sound now?
Can you try and talk a little more?
Okay. I'm still getting a little echo on my side.
So you have to, under audio, you have to select telephone instead of mic and speakers.
Okay, hang on 1 second. Let's see if we can get that switched.
Hello? Hello? Can
Hi,
you hear
is this
me?
Joel?
Yes. Can you hear me okay now?
Yes. Much better.
Sorry. Sorry to all the participants. I apologize for the complications. Okay, should we just start up at the beginning again?
Yeah, you can just go right into it.
Okay, great. Well, again, my apologies for the technology complication. What I began by talking about was that I can't tell you what's on the exam because I don't know what will be on the exam. What I can tell you is what I think is important to prepare for the exam. And the way I'm doing that is looking at two resources. One is the Core Competency Development Project that was developed by the Association of Schools of Public Health, now the Association of Schools and Programs in Public Health. In that document, for each discipline, they developed a series of competencies. The slide I'm showing now displays the 10 competencies that were identified for a course in health policy and management. Expectations for an MPH student upon graduation from their program. I will not read through the list. You will have that available for you as part of the PowerPoint. The secondary piece of that document are the interdisciplinary and cross-cutting competencies. Some of you have already participated in that seminar. Many of those overlap with health policy and management. As you can see, I've marked 4 of them with red arrows. I will address those, but probably not in as much detail as some of the other areas we're going to discuss. The second resource that I used in preparing the outline for today's session is developed by the National Board of Public Health Examiners, a panel of faculty who teach MPH courses in health policy and management discussed both by phone and online what they thought was important as content in a core course in health policy and management. And there's an outline of those topics that is provided as part of that report. Again, that will be part of the PowerPoint. Using those 2 resources, I tried to organize material for our conversation today. Before I begin the material, just as a little exercise, I have a series of short multiple choice questions, and nobody will see your responses to these, but just on a notepad, I'll give you about 20 seconds for each one as we go through them. Just make a note of what you think the correct answer is, and then at the end of my session we'll go back and we'll answer those. Okay, so for the first one, being awarded certification in public health from the National Board of Public Health Examiners as a result of successfully passing its examination is an example of structure, environment, process, outcome. And if you just take a couple seconds and make note of what you think is the correct answer to number 1. Okay, and I'm going to move on to question number 2 now. The smallest percentage of U.S. healthcare spending addresses one of the following: nursing services, public health services, physician services, pharmaceutical services, hospital services. And if you'll answer that one. Okay, continuing on to the third. Potential injury to research participants is best addressed in the Belmont report by A, respect, B, justice, C, litigation, D, assessment of benefits, or E, beneficence. Okay, continuing on. The U.S. Constitution empowers the detention of contagious individuals entering the U.S., and that's a true or false question. Question number 5. Paying a monthly flat fee for all medical care needed is typical of A, fee-for-service, B, health maintenance organization, C, preferred provider organization. Sixth question. Shriners Hospital for Children would be classified as A, sectarian, B, investor-owned, C, state government, D, non-sectarian, and E, federal government. Okay, a statement: by June 2013, there will be a 0.2% reduction in HIV infections in a strategic plan. This would be where you'd find this would be an example of a mission, vision, objective, goal, program. Okay, in regard to budgeting, for the recurring monthly restocking of flu vaccine addresses a variable cost, a charge, fixed cost, general cost. Is the context for what I'm going to talk about. I looked to a report from the National Academy of Science Institute of Medicine that talked about the future of the public's health in the 21st century. And it made the following points: that we need a health policy that assures adequate and sustained investment in the important determinants of health, a strong government public health infrastructure, and a public health system that reflects public understanding that health is business. And I think that the discipline of health policy and management contributes to those needs. Okay, so what we'll do as we proceed is I've divided the presentation into 4 topics: systems thinking, health policy, delivery systems, and then health management. I'll label each one as we move into it. In terms of system thinking, systems are complex, and some of you may know this game from when you were kids, the mousetrap game, which is like a bunch of plastic parts that you assemble, and basically things can go wrong. That the model starts out with that letter A, where you turn a crank, which moves a lever, which kicks a boot, which knocks a bucket over, and a marble rolls down the stairway, and then it falls into that track G and moves over and hits the pole. That the hand at the top of the pole pushes another marble, which rolls off into the bathtub and eventually drops and hits a diving board, where a little man bounces off the board into a tank of water, which then activates the basket that slides down that pole, trapping the mouse. And anybody who played that game when they were a kid It never works quite right that the marble gets stuck someplace or the basket doesn't fall on top of the mouse properly. And I think that's a great example of what can go wrong with a system. And if we think about healthcare in general or public health as a system, how do we integrate all of those pieces to work in an efficient manner? Okay, as I mentioned, I know you, if you were in the previous session, you talked a bit about systems. I always go back to the World Health Organization definition of health and the various components in this illustration, culture, community, lifestyle, self-care system, working environment, family, and how all of those things as a system contribute to health. So I think that it just represents an example. When about healthcare, and I thought that this one was, this cartoon was particularly appropriate, in light of some of the discussion in the presidential campaign. Can we have a complex system or a simple system in the United States to deliver our healthcare needs? Some people would argue that we don't have a healthcare system, that it's simply so complex that it's not an organized system. I think that each of those components does demonstrate interrelationships with each of the other components that exist. So it's how do we define our healthcare system that becomes extremely important. I think if we're going to narrow it down from that complex model, what we can talk about are three components: access to care, quality of care, and cost of care. And that's what I'll refer to as we proceed through my session. People frequently make comparisons of healthcare in various nations, and I have some tables we'll look at later in the session. In the United States, is the quality of care a factor that outweighs the cost of care? In other nations, do we look at a different model? What are the importance of the various components? I think there are other ways we can differentiate care. Is care in rural areas of the United States different than urban areas? Is the access to care, the cost of care, the quality of care different in a rural area than it is in a large city? We can look at the inputs, the various components that contribute: the personnel, the facilities, the technology and supplies, and the financial resources to construct the delivery system. And here's one that's a little bit more complex, where you can look at the external environment at the top of the page. I'm going to share some books as resources at the end of the session. This is from Longest and Dar's textbook on management. There are a variety of things that are beyond the control of the people delivering services in terms of the general environment. In addition, we have an external healthcare environment. What we look at is the internal environment, and as you can see, we can talk about the inputs, the methods we use, the conversion, and the outputs. And then in all cases that I'll talk about in systems, we eventually have some feedback for refinement of the process. One of the models that I particularly like is the Donabedian model that talks about quality, where we refer to structure for the delivery of services, a process for providing care, and then we measure outcomes, and ultimately we do feedback to fine-tune our activities. All of these things are being done in an environment of an external environment where we have less control. And in public health, here's one other example system where our goal is to assure the conditions of population health. What are the components equivalent to that mousetrap game that contribute to the system that we're concerned in delivering the best quality of services we might? Here's one final example. This is the Centers for Disease Control's example of a public health wheel. Three components: policy development, assurance, and assessment. And as you can see, under policy development, we have the essential components of informing, educating, and empowering, mobilizing community partnerships, and developing policies. Under insurance, enforcing laws, links to provide care, efforts to assure a competent workforce, and then finally evaluation. And then under assessment, we have monitoring of health and diagnosis and investigation. And you'll see that as an example in a variety of settings. Okay, so that's all I wanted to do is a quick overview of systems. You have an opportunity to type messages in the box on the right-hand side of the screen. If anybody has any questions as I proceed, I should have mentioned this earlier, feel free to type in a question and we can try to address it. Okay, I'm going to continue on and talk a little bit about health policy. I think that anybody who's watching the presidential debates, clearly we have one candidate, Senator Sanders, who's advocating for a single-payer system. Other people feel that would be less effective as an immediate implementation in the United States. Also this past week, I believe for the 60-something time, there was a vote in Congress to repeal the Affordable Care Act, frequently referred to as Obamacare. So when we're talking about the framework for policy, I think there are three components that are important. Policy formulation, followed by implementation, and again, as in all systems, some sort of fine-tuning through modification. We get feedback on what works and what does not work in our model and try to address the concerns that may exist. Again, I think this one is timely in regard to the presidential campaign. Do people understand the policy that we're talking about? This is a photograph that was taken at a demonstration, obviously. The central sign in the photograph, "Keep government out of my Medicare, you damn socialists." I think that anybody who understands Medicare does understand that it is a government program, and to try to refine the system without understanding that would certainly be a difficult task. Okay, so what's the legal basis for our policy? A lot of people, when I ask that question in class, will say the U.S. Constitution. And if I ask the next step about, well, what in the Constitution provides for health care, what frequently people refer to is this clause: "We, the people of the United States, in order to form a more perfect union, establish justice, ensure domestic tranquility, provide for the common defense, promote the general welfare, and secure the blessings of liberty." And they think about promoting the general welfare as the basis for healthcare services in the United States. I'm not an attorney, but my interpretation of a variety of legal cases is that does not have standing. What people typically point to is statutory authority. Here's an example. The Commerce Clause of the U.S. Constitution, which is the basis for Section 361 of the Public Health Service Code. And I doubt you would need to know that specific section number for the examination. But as an example, what it does is it provides for the U.S. Secretary of Health and Human Services to take measures to prevent the entry and spread of communicable diseases from foreign countries into the United States and between states. And that becomes a statutory authority for public health services. So if we go a step further, we talk about what statute or law refers to. I would categorize it in two ways: criminal law, which talks about conduct that's prohibited by government because it threatens and harms public safety and welfare, and civil law, which are actions intended to protect the public health and welfare. We also have specific police powers related to public health to encourage behavior. Those are frequently through coercive actions, quarantining people based on a contagious disease. seizing property that could do harm to the public, a product that's being imported from another nation that has some sort of chemical in it that would affect the users of the food product, as an example. Or to close businesses. I suspect a lot of you, notice signs when you visit restaurants in regard to their public health restaurant inspections reporting the quality of the restaurant. If they fail to meet standards, they can certainly be closed. Okay, another piece separate from the statutory authority is implementation through administrative regulations. Legislative bodies enact laws, and normally they authorize personnel within government to develop administrative regulations for the implementation of those laws. So it's important to look at the regulations as well as the original laws. So in developing policy, this is an example that I like, a checklist for the things you want to consider in developing a policy. First thing, what's the problem? And trying to develop a concise statement of the problem. Can I identify the focus? Can I identify options related to the solution of the problem? To talk about background, what factual information is necessary to address this effectively? Have you eliminated information that's extraneous, that's not relevant? Is the tone appropriate? And you want to keep things as neutral as possible in tone. Landscape. Who are the stakeholders? And I'll talk about stakeholders in a moment. Are the stakeholders' views described clearly and accurately? Is the structure of the landscape consistent and easy to follow? Is the landscape appropriate? Does the reader have all the information necessary to assess the option? And I think one of the important things in regard to stakeholders is they may not all have mutual perceptions or outcomes based on the policy that's being developed. Do my options directly address the issue identified in the problem statement? How do you stay germane to the issue? Do I assess pros and cons? What are the advantages and disadvantages of each option you've identified? Can you apply all of the criteria to each option in its assessment? How do you evaluate it? Are the options sufficiently different from each other to give the client a true choice, a real choice? Are all of the options within the power of the client? And then finally, a recommendation. Is my recommendation for one of those options appropriate and appropriately assessed? Can you recommend only one option, or are there multiple options? Are you explaining why your recommendations are the best option, and what are the flaws related to that, since few things are perfect? Okay, and here's one other example where we've got the formulation stage that I've just referred to on the left side, and then we talk about implementation, and it is in all of the examples I used related to system. At the top of the page, we have the external factors, the environmental factors that are brought to bear, and at the bottom of the page, the policy modification process. Based on our first initial activity and its assessment, how can we refine it to make it better as time progresses? Okay, in terms of the stakeholders, I think these 4 examples of stakeholders probably share a variety of common interests, but they may be different. As a consumer, you would like to pay as little as possible for your services, where providers, based on their income goals, may want to have a higher fee. The payers are going to have a role in regard to what's appropriate. Employers paying for insurance have a role. Who are all of the stakeholders? Those are only 4 examples. Who are all of the stakeholders involved in developing the policy, and what are their interests? Ideally, we can identify some common interests among the stakeholders. Okay, the ethical component of policy. How do we allocate resources? Using a pie rather than health services is the example. We can carve the pie into slices in a variety of ways. Will everybody get an equal size share? Will we give more pie for those who have gone without pie in the past? Will the most powerful people get the largest slices of pie? Will those who make the greatest contribution to making the pie or the healthcare system get the most as a result of their contribution? Should we say equal shares except for special cases? Or finally, those with the greatest need get the most? And at some point in policy, we need to decide how we're going to allocate our resources. Another aspect of ethics is developing a professional standard. Professions develop codes of ethics. Here's an example from the Public Health Leadership Society, where it defines code of ethics for public health, clarifying the distinctive elements of public health and the ethical principles that follow that definition. What are our ideals? And I've got a specific example that some of you may be familiar with. In some schools and programs in public health, as a new student week activity, welcoming people to the educational program, and in some cases as part of a commencement ceremony, students are asked to recite the public health professional's oath. And I won't read the whole thing, but I will read the first paragraph. At the University of Georgia, at our commencement ceremony, all MPH students and Doctor of Public Health students rise as part of the commencement ceremony, and they swear this oath as a public health professional. I hold sacred my duty to protect and promote the health of the public. I believe that working for the public's health is more than a job, it's a calling to public service. Success in this calling requires integrity, clarity of purpose, and above all, the trust of the public. Whenever threats to trust in my profession arise, I will counter them with bold actions and clear statements of my professional ethical responsibilities. So as I said, there's not a required professional code of ethics in public health, but it's been adopted in many academic settings as well as workplace settings. Many of you, as part of your training and research, have addressed the issue of ethics in research, the requirement for studies to be reviewed by institutional review boards. And you're probably familiar with the Tuskegee studies, excuse me, where a decision was made to withhold treatment from participants because it would disrupt the research. Excuse me. As a consequence of that, there was a report that's referred to as the Belmont Report. The Belmont Report refers to three core principles in terms of ethical research: respect for persons, the individuals who are being studied, protecting the autonomy of all people, and treating them with courtesy and respect, and allowing for informed consent. Researchers must be truthful and conduct no deception. Beneficence, the philosophy of do no harm while maximizing benefits for the research project and minimizing risks to the research subjects. And third, justice, ensuring reasonable, non-exploitive, and well-considered procedures that are fairly administered, fair distribution of costs and benefits to potential research participants, and that all are treated equally. And it's frequently, I'm sorry, I shouldn't say it, but those components are normally included in informed consent forms for research, as well as both the assessment of risks and the assessment of benefits in regard to studies being conducted. Okay, so let's go on. With those things in mind, we're ready to implement policy. In grade school, normally people talk about government, three branches of government: the legislative, executive, and judicial branches. I suspect all of you understand these things. If you're not familiar with the process, this is a little YouTube video that you may want to look at, which is going to talk about the process in a very efficient way. But just to summarize it real quickly, if we're talking about legislation, we have a parallel set of activities that take place in the House of Representatives and the Senate at the federal level. Most states have a very similar process. I think we have one state that has a single legislative house rather than two. But what we normally have is the introduction of a bill or proposal in one or both of the houses of Congress. It's ultimately assigned to a committee which can conduct hearings, develop reports related to it, can do amendments and make modifications to legislation. Ultimately, if they pass it at the committee level, it goes to the House as a whole or the Senate as a whole for consideration. If the bill is passed and it is identical in both places, it can move directly on to the President. Frequently, there are variations between the two chambers. And what we see is the need for a conference committee to resolve those differences. In some cases, they'll amend it to address the needs of both houses. In other instances, one house will simply accept the language of the other. At that point, it's sent on to the President for consideration to be signed into law. And there are really four options at that point. The President can sign the bill, accept it, and make it law. Option two, if there's not a congressional session in place, if there's a recess, a vacation, the bill becomes law after 10 days without a presidential signature. I misspoke when I said that. I'm sorry. Please bear with me on this cold that I have. That's during a session. When not in session, a bill does not become law without a signature, so that 10-day law would not apply. And then the fourth one is the President has the option to veto the bill, and then it would be up to the legislative branches to override the veto. As I mentioned, I believe this past week, once again, the House Senate passed a bill seeking to repeal the Affordable Care Act, but once again, it's certainly not going to move forward. Okay, so who implements the policy at the federal level? And each state might have some variation of this. Here's an organizational chart which just tries to summarize the various units of the U.S. Department of Health and Human Services. And people frequently think about that department as the primary federal agency responsible for issues concerning health care of the citizens of the United States. In reality, while it has a very important central focus, as you can see in this next slide, there are a variety of additional agencies of the federal government that also have responsibility for healthcare related policy. And each of those, in turn, is authorized through statute and budget for the implementation of policy. There's a few examples of policy going back in history. One of the first things that I can identify is in 1798, the U.S. Marine Hospital Service was established to serve merchant marine from the United States who would travel around the world and treat them for medical conditions, and particularly infectious conditions, on their return to the United States to protect the population of the country. 1918 is another financing example. The first federal grants going to states to provide public health services. And then there are a variety of other things, but I'm going to skip past those. Four other examples of noteworthy policy implementation. 1935, Social Security Act was enacted. 1965, both Medicare and Medicaid were enacted. And I suspect everybody's familiar with the difference between those two programs, so I won't take any time on that. 1906, the Pure Food and Drug Act, addressing safety of foods and cosmetics, prescription drugs, medical devices. And in 1963, the Clean Air Act, establishing enforcement related to air quality. So those are just examples of some of the policies that have been implemented at the federal level. Here are 3 examples of presidents who had leadership roles in regard to major initiatives. I've left that 4th square blank to see what we might see in the future, but obviously we'll have continuing evolution related to healthcare services. The Patient Protection Affordable Care Act, what's frequently referred to as Obamacare, I can't tell you how much would be on the examination, but makes sense to be familiar. If you're not familiar with that legislation, once again, this is a link to a YouTube video that does a nice, simple explanation as an overview of the legislation. In terms of the providers of public health, we can talk about both the private sector and the public sector in the form of government. We can divide it in the lower left-hand corner of the federal agencies we've talked about, lower right-hand corner talking about state responsibilities, in the upper right-hand corner talking about local agencies that provide public health, either municipal city government or county government or health districts that may exist around the country. I had a different example of this based on what's happened recently. Who are the responsible parties in regard to addressing what's currently taking place in Michigan? It looks as though we're going to see a variety of parties at the various layers of government, but I would anticipate we'll also see private sector involvement in addressing these problems. How will those be managed as a system? Who takes responsibility? Who pays for the services that will be developed? So, I think that we frequently have these complex systems that need to be managed, and it'll certainly be interesting to watch what happens in Michigan. I think I've already spoken to the private sector, so we'll skip past that one. And if you have any policy questions, once again, feel free to type a note in the message box on the right side of the screen. I'm just looking, it's 1:50. I'm about halfway through the session. Kate, what do you think about taking a 10-minute break at this point?
Yeah, that sounds great.
Great. It's like my clock says 1:47, so why don't we plan on starting at 2 o'clock?
Great.
Perfect. Thank you. Kate.
Hi, Jill.
Okay, I guess we give it a couple more seconds, then start up.
Yeah, sounds good.
Is pace okay so far, by the way?
Did you say space?
Yeah, pace, the speed I'm
pace.
going.
Yes.
Okay, good. It's like I feel like I'm running a little bit different speed with my cold. Just wanted to make sure.
You're fine.
Okay, great. Well, why don't we go ahead and start up again. Welcome back to everybody. And what we'll do now is transition into talking a bit about the healthcare delivery systems. So, you know, we're certainly going to talk about the perspective of public health, but we'll also talk about clinical care as well. If this were in a class, I'd ask the class to try to develop this list. The Centers for Disease Control developed a list of the top 10 achievements in public health over the past 10 years. I'll show them to you in a moment, but if you want, just take a second and think about what you believe might be on that list. Think of one example. Okay, now we'll just go ahead and take a look at what's on the list of our accomplishments in public health. CDC ranked them in the following order: vaccination, motor vehicle safety, safer workplaces, control of infectious diseases, decline in health from coronary heart disease and stroke, safer and healthier foods, healthier mothers and babies, family planning, fluoridation of drinking water, and recognition of tobacco use as a health hazard. So looking back at the evolution of public health, those are some of our key accomplishments. How did we get there? Obviously, one of the organizations we think about is a focal point for the public health activities at the federal level, CDC. If you want to understand a bit more about the relationship between CDC and local areas, I love to use this movie when I teach. Panic in the Streets was a film in 1950 starring Richard Widmark as an epidemiology intelligence service officer. It's available for, I think, about $2.99 at Apple, Amazon, and Netflix. And you can download and watch the movie, and it has the photograph that's on the screen shows Richard Widmark as the federal representative standing next to a New Orleans police officer in their investigation of an outbreak of plague. It's a fun movie to watch. So that is a way of looking at that interface between local and federal agencies. Obviously, we have the state health departments, and this is just an example of the website in Minnesota. And as you can see, topics indicate some of the activities that they define as their responsibilities at the State Department level in Minnesota. And then, of course, the local health departments, city, county, and districts. If we think about healthcare expenditures, we've had a slight decline in the rate of growth, but overall, as you can see, we've had ongoing increase in the total cost of healthcare expenditures within the United States. What do we use that money for? We'll look at that in a moment, but where does the money come from? I guess is the first thing we should start with. As you can see, the largest share comes from private health insurance paying for services that are provided, followed by Medicare, followed by Medicaid programs, and then several other types of programs, including out-of-pocket expenses. What do we do with the money? As you can see in this illustration, the primary activity is invested in hospital care, almost a third of total costs, followed by physician clinical services. Where does public health fit into this? If we look at all health expenditures in the United States, over time we've been talking about approximately 1% of all U.S. health expenditures going to public health activities. And in this illustration, it identifies some of the sources for that 1%. About a third of it's coming from federal agency support. A bit more than a third of it's coming from state agencies. And as you can see, the rest is divided between multiple sources, local funds, some fees and registrations, and then a variety of other mixed sources. I just looked yesterday at the federal omnibus appropriations bill that was passed. This is from a press release from House Speaker Ryan's office, which talked about 10 things you should know about the omnibus appropriations bill. 5 of those items talked about healthcare issues, and that's what I have on the slide. I picked out the 5 that addressed our topics. The first point that was made in the press release, overall discretionary spending has been reduced by $176 billion since fiscal year 2010. So what we're talking about is a reduction in funds that are being appropriated overall. The second point that's made, and actually it's misnumbered, it should be 6 points, I'm sorry. The bill cuts funding for EPA for the 5th consecutive year and reduces its staffing to the lowest level since 1989. No new funding for Obamacare or the Affordable Care Act. The bill maintains all existing pro-life policies and funding provisions. The bill continues our work to deliver a 21st century healthcare system for our veterans and their families. And then finally, the bill increases funding for the National Institutes of Health. Notably, the bill increases funding to boost Alzheimer's, cancer, and brain research, pediatric research, and emergency funding related to the Ebola crisis. So you can see as part of the implementation of policy related to delivery, we see some areas which are receiving increased funding, while concurrently other areas are either flat funding or actually decreases in funding. So when we talk about personal care, since that's such a large component of the delivery system, what are we talking about? Obviously, one component we can talk about is the preventive services and health promotion activities. Second area we can talk about is primary care. The activities where people go in for routine visits on a walk-in basis. Third area, hospital care, inpatient services. And I think example, although it might apply to other areas, we most frequently talk about it with hospitals, that how do we organize the services? And the first slice is to differentiate between private non-governmental ownership and government ownership. Within the private area, we can again differentiate between what are frequently called voluntary or not-for-profit organizations and investor-owned or for-profit organizations. Between those groups, probably the most notable distinction is in the voluntaries, talking about the sectarian or religious-based institutions that many religious denominations sponsor healthcare agencies and hospitals in particular, and the non-sectarian dealing with communities, charitable organizations. My question in the beginning of our session referred to the Shriners Hospital as an example. And one of the key distinctions related to those is under Federal Internal Revenue Service Code, qualifying as a not-for-profit 501c3 organization. I don't think you need to know that number, but the second category of the private agencies is the investor-owned or for-profit organizations. In some cases, those are single hospitals that are owned. In other cases, there are corporations that own several hospitals or 100 hospitals. Same thing might apply in ambulatory care, primary care activities. We're seeing growth in primary care clinics that are sponsored by Walgreens, by CVS, individually operated walk-in facilities. What's interesting on the government side is the diversity of services that are offered in terms of both federal, state, and local agencies. At the federal level, we certainly think about the branches of the military through the Department of Defense, the Veterans Administration hospitals, the Department of Health and Human Services offering services through agencies such as the Indian Health Service. The Department of Justice provides health care through the Bureau of Prisons. State level, I think the majority of inpatient facilities tend to be in these two categories. Mental health facilities that are operated by state government and public university academic medical centers. At the local level, we frequently see hospitals that are offered as either a hospital district or authority, as well as designed to municipal or county government agencies. But we can organize the nature of the facilities, whether we're talking about hospitals or long-term or primary care settings, based on those categories. One other type, with an aging population, we're seeing more and more attention to elder care or long-term care. We have a variety of types of activities to serve the aging population. How do we pay for their care? Fee-for-service is probably the dominant model, where you define a service, you set a price for it, and people pay for that explicit service. In the same way as shopping for products at Target, or having work done on your car, you're told what it costs and you can decide whether you want it or not. So we have fee-for-service care, but complementing it, we have growing sets of activities related to managed care. Managed care usually talks about, in a health maintenance organization, fee in exchange for all services you receive. Now, in an organized managed care system, there might also be activities to define what is appropriate care, to talk about preventive services that would reduce the cost of acute care services in the future, but a more organized model than the traditional fee-for-service framework. I mentioned earlier that we'd have a chance to look at some healthcare rankings. Here are two slides that came from the Commonwealth Fund, ranking industrialized nations based upon healthcare services. Regrettably, you can see at the bottom of the table, it lists the United States with a slightly lower score than Canada. Why do we rank lower than those other nations becomes the clear question. And this table has scores. As you can see, there's a column for each of the nations we were talking about. On the far left side, it's identifying the criteria that were used in establishing those rankings in terms of quality of care, access to care, efficiency of the system, equity, healthy lives, and finally the expenditures. So three of those categories refer to the things I mentioned earlier in systems: cost, quality, and access. I think one of the most notable things as you look at that is that the bottom row, when it talks about healthcare expenditures, the United States expenditure per capita is far more than any of the other nations that are listed. Okay, so that wraps up my framework for delivery systems. We're going to talk about one more area, health management. And what we frequently talk about in health management are those 5 pillars: service, quality, people, finance, and growth. I think one of the important things that we prepare people for in public health is to assume leadership roles, and I think that's a component, excuse me once again, an important component of education in public health as well as certification. I think the central focus in managing organizations is making effective decisions. And typically when we talk about management, we can talk about 5 areas that contribute to effective decision making. Excuse me. And those areas are planning, deciding in advance what we're going to do, organizing, developing relationships among the people and other resources to achieve those outcomes, staffing, the human resources that are necessary to implement our plans, directing how do we supervise people to implement what we want to accomplish, and finally controlling, regulating activities to achieve our outcomes. Okay, one of the important things that I think about in management that people frequently overlook, they think about the full-time staff of organizations. In most organizations, whether they're the government agencies or the private agencies we talked about, there's a governance structure, some sort of board of directors or board of trustees, board of regents, a variety of labels, but it's a governing body for the organization. Typically, those organizations that have a governing board, the board's responsibility is to set policy. They hire, and in some cases fire, the executive director or whatever the title of the senior level person is who's a full-time staff person, but they're not making decisions on the day-to-day operation of the organization. Their goal is to authorize a full-time person for implementation of the policy that they develop. Okay, so as we look at organization, we typically have that governing board, and then we have a number of staff that are full-time personnel within the organization with a responsibility to implement the vision and mission of the organization. There are some terms that I think are important to understand. Frequently when people draw organizational charts, they talk about line and staff. Line refers to somebody who has direct authority in the organizational chart to supervise other people. In this example, the Director of Public Health is the immediate supervisor of the Associate Director for Patient Care, as well as the Associate Director for Environmental Services. They have direct supervisory responsibility on those individuals. In contrast, the 2 boxes that are labeled Executive Assistant to the Director and Medical Director are people who do not have authority or supervisory responsibility over other individuals. They provide technical support to an individual in a line relationship, I'm sorry, in a staff relationship, that they support the individual that they're linked to. So you should know those 2 terms. Now, carrying a step further, as we organize, as an example, a public health agency, there are several different ways it can be accomplished, and here are some different models. The first example at the top of the page is organizing by function, where in my example we have 4 units that are under the authority of the director: a planning department, a public relations and communications department, a human resources department, a finance department. Each one has a very explicit function. In the second model, they're organized by geography, where everything is done based on a geographic unit. So in a large area, we could have the northern, eastern, southern, and western divisions. Each one would have its own components to function independently. A third way to organize would be around the clients that we serve. So you would have services for children, adolescents, adults, senior citizens. And in each case, there are a specific set of services to meet your client's needs most effectively. And then finally, the last organization example I have is organizing around a purpose. It's rather than the specific client, it's a specific service that you're providing in terms of purpose, such as well baby, health promotion, substance abuse. Typically, that's an oversimplified model for how an organization is going to work, but we can start with that. What we often end up with is something that looks more like this, which is a mix of those various models. So you can see the northern division of this department is organized in a different way than the southern division. That may be based on the demographics of the population. Some things are centralized at the top of the page, and we can have a variety of organizations that are designed to most efficiently achieve the desired outcomes of the organization. There's one other type of organization that pops up periodically, and that's called a matrix organization. In this case, if you look, you can see 4 columns, and the way they're organized going back by function. And on the left side of this one, you can see the same services we talked about over here under purpose. In the case of well baby service planning, that would have a responsibility reporting to the planning department in regard to their planning activities and whoever was in the supervisory role related to well baby services. In the case of well baby public relations and communications, same thing, that they would have 2 reporting lines. In some organizations, this works very effectively. Probably the greatest criticism is people suddenly have 2 supervisors that they're reporting to, and that makes it much more complicated to do your job. But we do see some organizations that are organized in this matrix model. Okay, so let's talk a little bit about human resources. One of the most critical things in an organization is the people who are employed within that organization. How do we recruit good people to apply for jobs? How do we evaluate them in terms of a screening process to make sure that they're well qualified for the jobs? And finally, how do we effectively hire them into positions that we have available? So what are the skills that are necessary to have a well-run organization in terms of the people who are involved? And we hear about a variety of different organizations and how they function. There are different types of interview processes that can be used to accomplish that. Here are some examples of some of the things we might look at in hiring in terms of individual characteristics, how they fit the specific job, and then how they fit the work environment that we're concerned with. One of the things that I frequently point to when I talk about it is one of the basic management theories, McGregor's theory of human motivation, which categorizes organizations in 2 different styles. One is referred to classical management, or theory X. The other is a behavioral approach in theory Y. Classical management tends to define its employees as being on the job for one reason, that they're there for a paycheck, that they're cogs in a process, they're easily replaced by other people, that there's no satisfaction in the job beyond their paycheck. And that if you turn your back on an employee, they're going to be goofing off, not doing their jobs well. In contrast, the behavioral approach says that employees are motivated by the nature of their work, that a happy employee is a good employee, that there are rewards to the accomplishment of doing your job well. Excuse me. And a supervisor approaching employees in one way or the other is going to have different outcomes depending on the employees. What's the appropriate approach? A more recent model talks about contingency theory, what's frequently called Theory Z, which is situational. And it says that there's not one best way to manage. In some instances, the job is routine and boring, and perhaps a more Theory X approach is appropriate. Where in other instances, based on the nature of the work, highly motivated people who feel a reward based on the accomplishments of their work, we should manage them in a very different way. So in a contingency theory model, we're going to make decisions based upon the nature of the work and the personnel we're supervising and decide on a best approach to meet their needs while achieving the outcomes that are the goals of the organization. Okay, so let's talk a little bit about strategic planning in that context. We frequently use these terms, and I think one of the ways to divide them up is in this illustration that we frequently talk about mission and vision. What I think we can do is say that the desired outcome in the future, mission is how we're going to accomplish it, vision is the desired optimal outcome. People frequently talk about strategies and tactics. I think that in most plans we talk about goals and objectives. I have occasionally run into a book or a reading that reverses that terminology, but most commonly goals are broad, general statements of outcome, where objectives are more specific outcomes, which are typically time-specific and measurable. And I think that's the norm, but it always makes sense to ask questions about that to make sure you're using the same terminology as the people you're working with. Here's an idealized model that I think is appropriate for strategic planning. And it has 4 levels. Where are we now? And that's assessment of the current situation. We gather information just as we did with our policy discussion. You're probably familiar with SWOT analysis, also called WATS analysis in some case, which talks about looking at the strengths, weaknesses, opportunities, and threats for an organization. And then proceed on to identify the specific issues and challenges that are highest priority for that organization. Once that's done, we can go to the second step, talking about where we should be going in the future. What are the alternative ways of dealing with the issues? And then developing specific outcomes, a vision for the organization, a mission for the organization, those broad statements of goals, and then the much more specific objectives that we'd like to accomplish. We then take that to the question of how do we achieve those outcomes? What are the best strategies? And in assessing strategies, we always need to think about resources, and typically we develop 2 types of budget. It's capital and operating budgets for that outcome. And I'll talk a bit about budgets in a moment. Then once we get through the formulation stage, we're ready to start talking implementation. Frequently, we have to have some sort of management information system that can gather and monitor data. We do ongoing performance evaluation, and then we do some adjustment. And once again, in all the systems, we talk about using the outcomes as feedback to go back and start over based on the successes as well as the failures of our initial implementation strategies. So that's just an example of one of many models that could be used for strategic planning. Just some examples, browsing the web, I looked at some of the examples of strategic plans that you can see on the web. If you're looking for an example, it's fairly easy to search and find a variety of examples. One that I did select to share with you is the Federal Initiative Healthy People, which develops a variety of specific objectives. And as you can see, These are very specific, as I mentioned a moment ago, in terms of trying to quantify them and making them very specific for measurement purposes. Once again, in their model for healthy people, there's an example that talks about the type of feedback we've been looking at in systems in general. Okay, just 3 economic terms that we use in management that I thought were worth mentioning. The difference between needs, wants, and demands. Needs, that's a perception by individuals. Their felt needs are what they're deprived of, whether it's physical, social, or individual needs. What do they need based on a perception? Wants take it a step further, and they talk about some sort of formal process to evaluate what is required. Demand takes it even a step further by talking about the financial aspect. I would like to buy a Tesla car. I'm not going to get one though, because I'm not willing to pay what they charge for it. So I'm not creating demand for a Tesla. I want one. Do I really need one based on transportation, or can I just use a bus? So we differentiate those categories, and it's just good to know those terms. One other way to look at it is in terms of marketing strategies. We frequently talk about in marketing the 4 P's of marketing, and in some cases the 5 P's of marketing. The top labels are the examples that when people talk about the 4 P's in marketing, they're talking about the product, its price, its place or location where it's offered, and the promotional activities related to marketing that service. If people talk about 5 P's, they have that 5th column of people. What I like to think about, and this is looking at the 10 essential health services that we talked about earlier, is to create this sort of matrix and think about what for each of those services would be the product, what would be the price to provide that product, where would we provide it, what's the location, how do we promote it, and then who are the people who would be involved related to that service. So I think there are a variety of models, but frequently people use the 4 P's or the 5 P's of marketing. Okay, in terms of finance, we only wish that we had, stacks of cash to spend on public health services like Scrooge McDuck, but one of the things we want to do is talk about how we can use financial information to improve decision making and manage our resources. The ability to pay for services is an extremely important component in anything that we plan to do. And we want to talk about some specific terms. Frequently people use these 2 terms interchangeably, cost and charges. I think that it's important to differentiate them. The cost is identifying the financial resources that are required to provide a good or service. When you're talking with a friend who has the ability to get you a good deal on a product or service, they frequently say, I can get it for you for the cost. What charges are an add-on on cost. It's what you're asked to pay, that if somebody can buy that Tesla for a certain amount of money, that the person reselling it wants to have some additional money to pay for the personnel that are involved in an auto dealership perhaps, the profit margin and so on. So it's going to be more than the cost of the car. So it's important to know those 2 terms. 2 other terms that are important are fixed cost and variable cost. A fixed cost is something that's constant and reliable, where if you rent an apartment, you know it's going to cost the same thing every month during the lease period, that it's going to be the same amount of money on a recurring basis. In contrast, a hospital or a motel or a hotel, how many patients will they have in a given day may change. And if they're apportioning the cost for heating the building and only half the beds in the hospital are filled, they can't turn the temperature down just because there are less people there. So there are some things that are variable. The more people that are in patients in a hospital, the higher their costs will be for food services. So there may be some things that change in a variable cost model. Some other terms, capital budget. We're talking about the overall high value long-term assets, things that cost money over time, the big purchases of equipment. In contrast, the operating budget is talking about the expenses for a given time period. And we can break that out into those 4 categories. So we differentiate between capital budgets, the big purchases, and the day-to-day operations of an organization. I've already talked about for-profit and not-for-profit. I think the most important thing, just to reiterate this issue, is frequently people mix the terms not-for-profit and non-profit. I think that an organization that's classified by the IRS as not-for-profit may still need to make a profit. Now, they might not call it a profit, they may call it surplus revenue, but in terms of replacement of equipment over time, they need to bank away some cash. If you charge exactly what it costs for a service, you're not going to have that surplus revenue. Health informatics is becoming increasingly important. We're seeing growing emphasis on health information systems and electronic medical records. I don't think you need to go into great detail about that, but I do think it's important to be aware of those issues. I'm just trying to think other issues related to the workforce. We talked a little bit about human resources. Here are some of the other things that I can think of. The Association of Schools of Public Health looked to the future several years ago, and based on the age of employees working in the public health workforce, recognized that, as you can see in this poster that was developed, more than 250,000 people working in public health would be eligible to retire from their jobs by the year 2020. The question then becomes, who is going to replace those people and fill in those jobs? For people who are just finishing school, that may present some interesting opportunities for advancement in a very rapid way. I think, and this is my opinion rather than anything else, I think that the retirements have been a bit slower in public health than might have been initially anticipated. I think part of that was the uncertainty of the economy. So now the question is, with the economy improving, will we see a more rapid rate of retirements among people in the public health workforce in the next few years, creating vacancies? How do we properly train people to work in public health? What's the appropriate training? Is it an MPH degree? Is it a degree in nursing? Is it a degree in business? Is it a degree in social work? Obviously, I think it's public health, and I suspect, since you're participating in this call, that you share that value that people trained in public health should be assuming these jobs. How do we evaluate the quality of those individuals that we may be hiring to fill those vacancies? One of the things that I'm always fascinated by is, what's the minimum standard? And when I put this slide together in regard to driver's licenses, does having a driver's license mean you're a good driver? I think in reality what it says is anybody who has a driver's license met the bare minimum standard to qualify for a driver's license. And for several movies earlier, one of the other movies I can think of is Dustin Hoffman in the movie Rain Man, where he refers to himself as a very, very good driver and bumps into a curb while driving the car. So I think that frequently what we're talking about in terms of quality as a licensure criterion is saying you meet a minimum standard. I think that that may be the first thing we think about as we talk about the certification process that you're looking at, that it differentiates you from other people because you meet that standard. Does it mean that you excel? We don't talk about people in the same way we do frequently in a master's degree program or a doctoral program where they received an A versus a B in the course, but everybody who passes it is certified. And I think that's a great step forward in credentialing public health professionals. Will we go a step further in the future and differentiate people beyond that is something that the National Board may have to address at some point. Excuse me. Hospital accreditation has been around for a long time, and this is just an example of the website of the Joint Commission International. What began as accreditation of hospitals in the United States is now spread worldwide in terms of setting standards for hospitals. Even with that standard of accreditation, National Academy of Science Institute of Medicine estimated that between 44,000 and 98,000 deaths occur annually due to adverse events in hospitals, and there are over 1 million injuries among the patients in hospitals. So even though hospitals are accredited, they're still not avoiding some of the injuries to their patients that we'd like to see them address. How about public health? Until only recently, we didn't have a standard for local health departments or state health departments. FAB, the Public Health Accreditation Board, was established for that purpose. This is an old image, as you can see, because it's talking about 2011. When I went to their website yesterday, for some reason it was down. It just wasn't working, and I wasn't able to get an updated version of this image. But the Public Health Accreditation Board has a requirement for health agencies where there are a set of standards followed by a site visit to the agency to demonstrate that they meet a national accreditation standard. If you go to their website when it's working, it'll give you a list of all of the agencies that currently have been met and now meet the accreditation standard. So in doing this, we always talk about some sort of continuous quality management process. This is a simplified version of what people are doing. The strategic planning process is part of plan, do the implementation process, check, which is evaluation, and then specific actions. And it's a continuous loop where we're, rather than doing it one time, we are continuously repeating it over and over with the goal of each time improving upon the previous experience. There's also another model, and I'll just briefly mention it, the Baldrige National Performance Excellence Model. To date, there's not yet been a health department that's been recognized with this national prestigious award. There are a number of hospitals that have received it. And as you can see from their model, they look at leadership, strategic planning, the focus on the various markets of patients and other customers. They look at their staff, the process management, and results. And as in all of the systems we've talked about, they're looking at the external environment and how they measure information. I look forward to seeing the first health department that, rather than simply meeting a standard for accreditation, exceeds that standard through a framework such as Baldrige. Some people, and I'll just spend a moment on this, some people talk about an industrial standard which is called Six Sigma. Basically what that says is that whatever processes you're involved in, there be no more than 3.4 defects or errors per million opportunities. So if we were talking about delivering babies, we would have no more than 3.4 mistakes in the million births of babies. Some people would say that's fine if you're manufacturing cars, but there shouldn't even be 3.4 errors in the birth of babies. It's an ongoing process, and as you can see from these examples of Arnold Schwarzenegger, if you don't maintain the process, you lose ground in it. Okay, so that wraps up what I wanted to talk about with management. So to summarize some things, I don't know what's on the examination. What I can tell you is there's a framework to help you study and prepare for the examination, both in terms of the ASPH competencies and the National Board of Public Health Examiners curriculum model. Those are good guidance. Let's go back to the questions. First question, we talked about being awarded certification in public health as a result of successfully passing the examination is an example of an outcome. And I really had trouble phrasing that terminology, because if you said being awarded the examination, being awarded the certification, that could also talk about studying for it, which would be a process. So, it's like, I think you have to be very precise in the terminology. And, I suspect that Dr. Peterson, when she talked about, the cross-cutting competencies, probably talked a little bit about, the nature of the exam. Read the questions carefully. Oops. Okay, here we go. The smallest percentage of U.S. healthcare spending addresses, and as I pointed out, we're talking about something in the range of 1% of all healthcare expenditures going to public health. So it's obviously answer B. Potential injury to research participants is addressed in the Belmont report by beneficence. U.S. Constitution empowers detention of contagious individuals entering the U.S. It's not that specific. It's statutory authority that addresses that. Paying a monthly fee for all medical care needed is typical of a health maintenance organization. Fee for service is based on the specific fees you're providing. Preferred provider organizations, I actually took that out of my presentation today, but that tends to be a mix where it can be a combination of both prepayment and fee for service. Excuse me. Shriners Hospital for Children. First off, we know it's a not-for-profit. Second thing, we know it's not affiliated with a religious organization, so it would be a non-sectarian organization. By June 2016, I think I might have had a different number, different year, and not updated it at the top of the presentation. By a specific date, there will be a specific reduction in HIV infections. That's very precise, so it's a goal. If it's said, in the future, there will be a reduction in HIV infections, or even within 5 years, there will be a reduction, that would more likely be a goal. And then we could have a mission related to reducing HIV in the United States or another nation as a mission. Budgeting. Budget for a recurring monthly expense is going to be a fixed cost. If we knew that flu vaccine was going to be administered only during 4 months of the winter, rather than every month of the year, it wouldn't be a recurring monthly investment or expenditure, and then it would become a variable cost. If we said at our clinic, the vaccine costs us X dollars, let's say it's $3 per vaccination, and we charge people $15, that would be the difference between a cost and a charge. Okay, a couple examples of books, and I've taken several of my illustrations out of these books. As I mentioned, I can't teach a course in a few hours. I can talk about important topics. Some of the books that I think would be useful is review Williams and Torrens, longest book on policy. There's another longest book coming up as well. Scutchfield and Keck, which has a much more general public health orientation and chapters on each of the topics we've discussed. The fundamentals of the U.S. healthcare system looks at some of the more broad issues in public health. This is longest in DAR, addressing managing health services, organizations, and services. Essentials of Public Health. This one is, this book and the next one are paperbacks which are much more concise. They're probably not as detailed, but in review they may be appropriate. This one looks at the broad issue of public health. This one looks very specifically at management and leadership in public health. So I think those are examples of study materials that you might want to look at. I wish all of you great success in the examination. I'd like to see you all do well on it. And that wraps up everything I wanted to share. Are there any questions that I can answer before we tie things together? Kate, I don't see any questions. Am I correct?
There are a couple. Let me see.
Oh, I can't see them. So if you could share them, that would be great.
I have one from Beatrice saying it can be argued that appropriations government funding is the most important aspect of policy, particularly when it comes to public health. Can you please speak to this?
Sure. It's like it sounds like Beatrice believes that, and I agree that one of the things I'm doing in one of the courses I'm teaching right now is looking at some things I found just by searching the web about local health departments that are currently experiencing a budget cut. And as a result of that budget cut, how are they going to change the services that they are providing? One way, obviously, is to cut back on a specific service. Another way is to reduce the staff that's available. And the third way is that there may be a new issue that they need to confront, which they aren't capable of taking on and adding a new service to the population they serve. So I absolutely agree that we're struggling with this issue of appropriations. Speaker Ryan's press release points out budget cuts related to the Environmental Protection Agency. He points to that as a positive. I suspect there are an equal number of people who would point to that as a negative, reducing the ability of that agency to achieve its specific mission. So I absolutely agree with that point. And part of it is policy issues in terms of the beliefs of different individuals in elected office. But the other thing is beyond things that are beyond the control of those individuals. With the shrinking economy, local health departments may be affected by a reduction in tax revenues for their service area, where the budget is cut simply because the funding isn't available. So I hope that helps. Kate, anything else?
Regarding health records and electronic health records, should we be familiar with HIPAA requirements for EMR?
That's a good point. Of course, I don't know what will be on the exam, but the HIPAA compliance records relate to the confidentiality of information. One of the most severe things that's happened recently, and I guess is on an ongoing basis, as we've moved to electronic medical records, are laptop computers that have been misplaced, stolen, or lost, which have a large amount of confidential information on them. But the other thing is simply in a healthcare facility, people, without thinking about the consequences, talking about a patient in a public place where other people can overhear it. As I said, I don't know if there are going to be questions in regard to compliance, but it's certainly something that everybody should be aware of, and that's a good suggestion. That I should have added that when I briefly mentioned health information.
There's a delivery systems question. You mentioned that the university-run academic medical centers fall under state government. However, since most universities are not-for-profit, wouldn't that make them non-governmental?
Well, it varies. It's like I may have overstated it with that comment. In some states, the universities are governed as a portion of a state agency within government. In other instances, the academic health science centers are treated as a freestanding not-for-profit entity rather than part of state government, and it does vary. And that's a very good point, that, to understand the exact organization would be important. It may be one structure in Illinois and a different one in Kentucky. So, I think that's an important issue. I know in some states they've decided that they are more efficient in their operations if they're freestanding rather than as an agency of government.
And there's one last question. Can you go back over the difference between vision, objective, and goal, how to distinguish
Sure.
a goal versus an objective?
Let me go back over, let's see if we can get back there quickly. Bear with me 1 second. We're almost there. There we go. Okay, so in defining direction, what we're typically talking about is a vision, which is some sort of ideal state for the future. And when I talk about strategic planning, if I were working with a group, I'd say if resources were unlimited, if there weren't barriers, what's your ideal future? When we get to mission, I think it makes more sense to talk about the specific organization because we can't guarantee world happiness in most cases. What should your organization seek to accomplish in a long-range manner? Looking out 10, 15 years in the future, what would you like to accomplish? Goals are more specific than that broad statement. And typically an organization is going to have multiple goals. They're going to be perhaps 5 years in the future, maybe 10 years in the future. They're going to be fairly broad statements of a desired outcome. When we get to objectives, I think objectives become very time-specific and very measurable. What are we going to accomplish in the next year, the next 2 years, the next 3 years? How can we measure that? And if you asked me a question about a goal, I could say, yeah, we're moving that direction. But if you ask me a question about an objective, which is very specific, at the end of the time period that's specified, we can measure it, and I'm not going to be able to finesse it. I'm going to be in a position where I say, yes, we accomplished it, or no, we didn't accomplish it. I think that that motivates people to focus on outcomes in a much more direct manner than those more broad statements, but they filter down from the mission statement to the goals to the objectives. And it's like, we could talk about that a long time. That's kind of an overview. If whoever asked that wants to follow up, I'd be happy to do it by email. Anything else, Kate?
Yeah, we're having a couple more questions come in.
Sure.
Should local health departments move away from direct delivery of services and re-engineer to managed care model?
Oh, that sounds like a policy question. I think that I can't answer that one. I could share my opinion, but I think that the issue related to that one is probably much more focused within the environment of that department that you're talking about and the resources that are available within that community. So I don't think there's one best answer to that. I think that's going to be variable. And again, that's just opinion rather than fact that I'm stating as I provide that information.
Okay. Could you please talk about the role of government in gentrification in relation to public health?
Oh, that's a tough one. And I wonder if that in the environmental health review, they'll talk a little bit about gentrification, but clearly there are some issues related to changes in the service community. I used an example in a comprehensive examination last year where we talked about gentrification in an urban area and displacement of the former community. I think once again, there's a policy issue tied to that. I think that, you know, it's going to vary with the community as well. You guys are asking tough questions.
I think that's
Anything
it,
else?
Joel.
Great. Well, it's like, you know, I hope this was useful. As I said, you know, I think that it's hard to cover all of the material. Certainly, you can't teach a course in a few hours, but you know, the goal is to at least help you become sensitive to some of the issues that you're well prepared for, and perhaps identify some that you might be have need to go back and review other resources for. I wish everyone success in the examination, and I look forward to you wearing a little badge at meetings that says you're a CPH. Okay, thank you so much.
Thank you so much, Joel.
Okay, and again, my apologies for coughing and our slow start, but hopefully this was useful.
Thank you, everybody, for participating. We will be distributing the slides by email, and they will also be uploaded to the website this week. Thank you, and have a great day.
Okay, thank you.